Hello everyone, welcome back to the Rethinking ADHD podcast. And today we're thinking about getting clarity in complex cases. My name is Jess Brunette. I'm the clinical team manager here at QbCheck, and my background is as an advanced nurse practitioner and non-medical prescriber. I'm joined by my colleagues today. Matt.
My name's Matt Tutts. I'm a clinical advisor at QbCheck. My background is a mental health nurse working in CAMS.
Hi, my name's Penny Lazelle. I'm a senior clinical advisor for the UK at QbCheck, and my background is a general nurse, health visitor, and also working in a community pediatric assessment team.
Hi, I'm Amy Sarah. I'm a clinical advisor and I am a RMN and non-medical prescriber.
Okay, so along the lines of getting clarity in complex cases in our ADHD assessment, we're going to be thinking today and pooling all of our resources really across the lifespan of ADHD care. We've got CAMS and pediatric background, health visiting, and also adult ADHD care as well. And so we're going to be touching on things like substance misuse, trauma and ACEs, physical health needs, and mental health needs as well. And Amy, within your adult ADHD setting, you have worked with a number of individuals with co-occurring substance misuse conditions. And I was reading recently in Nature that the comorbidity of substance misuse disorder in ADHD is over 50%, whereas in the general population, it's approximately 4 to 5%. So that's a massive jump up. And I'd be really interested to hear what your experience is of this in clinic in the adult population.
I mean, it's definitely, it's huge really. Whenever I used to sort of assess patients, I would have to be really aware about their drug and alcohol history and the risk as well. Often I would ask, patients, how much do you drink? How do you use any substances? And they were always really honest with me, and they would say, actually, I take cocaine quite regularly. And it was always when you'd ask them, oh, why are you taking it? And what's the reason why you're taking it for? That's when you get a bit more clarity about kind of the nature of the drug use. And 9 times out of 10 it was always just to feel normal, just to like kind of have that kind of being able to function, do normal things that most people are able to do without drugs. But this is the reason why they used to take it, to kind of regulate their emotions and give them that sort of reward effect as well that people with ADHD don't have. So it was about kind of finding out that information and getting more depth to that. But yeah, it was really common to see.
And how, when you're thinking about clinical practice, because you mentioned a little bit around reward seeking there as well, and we know in ADHD impulsivity, there's a lot of that dopamine seeking behaviors. And so how did you unpick clinically the impact of the substance misuse, whether it's been acute or longer term, the impact on their cognitive well-being, mental health, or just the side effects of the drugs in general versus those ADHD symptomology?
Yeah, so it was just again about asking them, how long they've been using for, how how often they use, and kind of there's a lot of similarities between how people present when they're intoxicated to someone who has ADHD. It's about getting to know a little bit more about that and how they feel, when they're not using, what their behaviour is like, what their mental state is like, and just kind of it's a good detailed comprehensive interview is always going to help with that. And always, probing to get more information from the person as opposed to just kind of leaving it at face value.
And I've done a bit of lifespan work, so although I focus primarily in CAMS, I've worked a lot around county lines and substance misuse in kind of teenagers and young adults. And I suppose it's the same in adults in kind of understanding that onset and what were those presenting behaviours prior to the onset of utilising substances as well.
Yeah. It can be quite challenging at times because often people, particularly like adults, are really ingrained in their misuse, and it's been several years since they've had any sort of period of time when they've been not using drugs. So that's really important to have any collateral information as well. So talking to like parents, partners, relatives who've seen that person prior to their substance misuse and also during, and they can give you that information as well to kind of assess whether they presented this, with ADHD symptoms prior to their drug use.
And I guess when we're thinking around kind of genetic predisposition, the adults that you are potentially seeing in clinic with the substance misuse, Penny may have been seeing seeing their children as a health visitor, and we may have been seeing them in our CAMS and pediatric clinics. And I have done a lot of work where young people who've come in for an ADHD assessment with me, but have been exposed to drugs or alcohol in utero. And at that point, we're thinking around FASD or the impact on frontal lobe development based on the substances in utero, and then how that impacts behavior. And you get more of those kind of hyperactive, impulsive behaviors, and trying to tease those things apart. It's an interesting debate as to how far you can unpick those behaviors and how we're looking at the person as a whole. And Penny, I'd be really curious of your experience, having seen kind of development from babies and then working in your ADHD clinic, but also your sleep practice as well. What's your experience here?
I think it's really interesting listening to Amy, because I've actually learned so much sitting on the sofa just in the last couple of minutes around the impact of sort of co-occurring substance abuse and addiction. And for me, when I was even health visiting and in my pediatric clinic, I'm not sure I really understood how impactful that can be on that child's development and subsequent potential ADHD. And the parents may also have undiagnosed ADHD, and that's why they've been impacted by substance misuse. So when we look at it, it's a much bigger picture than I think a lot of us think about. And thinking about when I was in my working in the community paediatric clinic, I don't think those questions were really asked. It was very child focused, and we're looking at the more common, possibly co-occurring conditions, and not really even delving into the impact of in that child in utero. I don't think I wouldn't have particularly asked in-depth questions to the parents. I would say things like, was your baby born at term, or was your baby premature, but never got in any more depth than that. And often it hadn't been written in previous records anyway. Yeah. So I think when we are talking about co-occurring conditions, we need to be looking at where have these come from.
Well, and I guess we get some defining physical health characteristics, don't we? When we're thinking about FASD, so fetal alcohol spectrum disorder, you have the changes to the philtrum, the smoother philtrum, you've got the teardrop-shaped eyes, alongside the behavioural needs as well. And so you're right, it's really unpicking the understanding around the clinical history and getting that long-term understanding around the environment. And we've talked in some of these podcasts already around the biopsychosocial model, and we need to think about the impact of the environment and that stress vulnerability model, that kind of at what point do we start expressing these genes or these traits based on our environment going on around us. And there also becomes risk when you're thinking about ADHD. And I've seen a number of young people who have been in like specialist school provisions, we call them PRUs down here in London, but where exploitation, grooming into gang culture comes in. And again, you're thinking about the early history of that child. They may have been scaffolded, symptoms nurtured, but actually that impulsivity and that vulnerability means that the potential of, okay, well, you could earn some money here, or if you just carried this, we would do that for you. And you get exploitation in that way as well. And substance misuse, such as I've seen a lot of cannabis use in clinic. We've talked about nicotine, lots of vaping use as well, all comes into play. And Matt, you also worked in CAMS. Have you got much of a background with county lines and this side of things?
As you've been talking, I've got a couple of old patients in mind in particular, but always found with the county lines, it was very much picking on the really vulnerable individuals. And I think we know that those with ADHD or ADHD-like difficulties or co-occurring needs, there is a little bit of vulnerability there. And I think I'm thinking back to, again, some of those old patients where they would come in from school and they've been having a bad time, and actually they're talking about this guy that, he showed me these really nice new trainers. And then you start to think about those, okay, I need to think about that. Why is that happening? But also thinking about what that means for that patient. And they are being isolated and they are being exploited. And actually, can we help if we can get some of those symptoms under control? Can we help them make good decisions without that impulsivity behind it?
And I guess when you mentioned reward pathways earlier, Amy, as well, that kind of instant gratification of, or the adrenaline of being vulnerable to this kind of criminal culture is something that we need to keep in mind. And within our clinical sphere is highly important to keep on our radar, to understand, okay, yes, this young person is presenting in a particular way, or maybe this adult is interacting in a way that their family members are finding abrupt or out of character. So we need to be asking the right questions and the hard-hitting questions to ensure that person feels safe enough to open up, but we can really understand their experience. I'm also really mindful that a number of the young people that I've worked with, but also when I've been doing lifespan work with adults as well, trauma and adverse experiences plays a huge role in that, to the point where I think we underestimate it. And we know that trauma in the early years impacts development of the frontal lobe, doesn't it? So your ability to press stop, manage your impulsivity, emotionally regulate. And when you were in clinic, you can see a highly emotionally dysregulated individual, which can lead into highly dysregulated adult based on their trauma history. And it's, again, easy to say, have you had any challenging life experiences, and kind of gloss over that. But I'd be, again, really curious with the expertise on the couch. What's your understanding of the trauma ADHD overlap? How do you tease those things apart?
So I think it is incredibly complex. And I think, as you say, when often we don't find ourselves either having the time or the sort of the knowledge, particularly the education, to actually ask those questions around life experiences. So in that clinic situation, well, from my experience, the use of objective testing can quite often pull out these other nuances, which can then sort of support you raising those questions to ask, particularly with dysregulation. We can often see that on objective testing. And we can then think, well, why is this person showing up as looking as though they're dysregulated? And maybe start asking those other questions. We're seeing something that maybe in addition to ADHD, perhaps there is a question that we need to just sort of dig a little bit deeper.
And utilising subjective measures, so alongside your objective tools, I'm thinking about, I use the impact of events scale a lot, which has also been, for those who are familiar with the IAPT framework, the Improving Access to Psychological Therapies, as part of that kind of cork bracket of approved tools. And that can also open up a little bit of a narrative, I think, to talk about flashbacks, nightmares, and understanding the impact of what we call tiny T's, the smaller traumas which have built up that have impacted that person over time. I think you can sometimes view trauma as a kind of significant large event, but we know, I guess, particularly in young people, working with young people, that it could be things like significant house moves, a change in family dynamics, even the individual undergoing a particular sort of surgery, or children view the world differently if they have perceived a threat that their significant adult or carer may have been impacted as sibling. all of those things can lead to traumatic outcomes. And I tend to find that when I'm unpicking that in clinic, the difference between ADHD symptoms versus trauma symptoms is that there's often a switch with the trauma symptoms, even if it's been a small build-up. And have you guys seen that as well, in that there's a significant events which then suddenly these behaviours appear?
Yeah, no, it's interesting when you say that, because when you ask, adults about their sort of history and like mental health, for just talking about trauma there, it's face value. Someone could appear really absent-minded, and that can present as someone who's like really inattentive, not listening, not concentrating. But when really you delve into the reason why they're like that, you then find out actually it's dissociative, that it's a trauma response. They've had a really traumatic event happen in their lives, and actually that's their way of escaping and coping. And, getting to know exactly the rationale and delving in deeper, you then get that clarity. Whereas if you just accept it at face value and not explore it further, you would just, think, oh, well, they're inattentive, when actually, and that can result in like misdiagnosis, which is really...
And I think that's a really good point, because what I have found is that dissociation can present slightly different to mind wandering. Mind wandering, you get that kind of like, you were on a thread, you kind of start thinking about something else. What am I going to have for dinner? Dissociation seems to be more of a blank. I'm physically in the room, but my brain has shut down to protect me. And when trying to unpick that, the difference between inattention, which is my mind is elsewhere, versus dissociation, where my mind has stopped so that I can protect and preserve. And you get the other trauma responses. We have fight, flight, and freeze and flop. We don't think of as often, but quite common experience is that freeze. Yeah. And that can also sometimes, you can be trying to unpick neurological conditions there, because you're like, is this an epileptic event? Or are we seeing a trauma response here as well? And so kind of getting that understanding around trauma history is highly important. I would also be curious, because I have also worked with a number of individuals with ADHD, where the ADHD and the trauma are linked. So there's twofold. One where the person has experienced a really traumatic event, but doesn't really retain it and doesn't have a trauma response because their brain was already 5 steps ahead. And it's actually, the ADHD is served as a bit of a protective mechanism. But also where I have worked with adults and done some lifespan work, I was predominantly working with women and saw huge amounts of domestic violence in undiagnosed women with ADHD and ASC. And a lot of that kind of narrative that they had done something wrong, and combining that with rejection sensitivity as well. And so when you think about how that manifests as a child, you've got different attachment styles. And then as adults, you've got trauma, rejection sensitivity. There's a lot to unpick there. You're all nodding. Does anyone want to jump in on any of those topics?
This takes me back to that child in the classroom or at preschool where, right from the early days, or they might, the baby that didn't sleep because the parent may have had a traumatic delivery, and that was their trauma. But that child gets to a preschool in a group of children, or sort of the early years in school, and is immediately identified as the naughty child, or potentially the quiet child that sits in the background, and that's all they're thought of, just the naughty child, the quiet child, but often no more exploration is made at that point until things get out of hand in that classroom of 30 children where they start to get noticed. And then I think just because of the way that we're educated, it's ADHD. Let's put an assessment. Let's put an assessment into secondary care. They sit on a waiting list for 3 years, and by that time, things have got really out of hand. So my big question at the moment is, how early is too early to start sort of looking into what else might be going on for this child? What co-occurring conditions may happen? Because before you know it, they're in that
in the system.
Yeah. And they're getting excluded from school. They've joined the gangs. They start to. So we can see right from the early.
Yeah.
And what's also interesting, and you've kind of reminded me, and you guys would have had me harp on about this so much, but what is the function of that behaviour? Because no child wants to be seen as different or reprimanded, and no adult wants to be singled out for their behaviour, whether it's they're the alcoholic in the family or this or that. What is underlying and driving those behaviours? And I think it's really easy to look on the surface, see this behaviour in isolation and not unpick what's driving it, where the onset was and what's underneath. And working in CAMS clinics, so child and adolescent mental health, I was really fortunate to work with a number of therapeutic colleagues who taught me a lot about transference. And I recall doing a number of school observations or just being in clinic with children who had attachment needs, and how they interact with you as the adult is very different, and again can help you unpick that ADHD. There's that impulsiveness, I want to tell you the answer because I know it and I want you to see that, versus the child that goes, did I get this right? Did I do okay? Who's hyper vigilant around the adults in the room, checking where the door is. They're hyper vigilant to all of the noises in the room. They're making sure that your emotions are in check as an unknown adult. Maybe as a female or as a male in the room, they're going to interact with you differently based on experiences. And these are the things that you're drawing out in clinic when you're trying to understand the difference between adverse childhood experiences, attachment styles, and also ADHD symptoms. We're a bit more fortunate with autistic spectrum condition because we've got the Coventry Grid, which is the written model to unpick attachment styles versus ASC. But I found it quite beneficial in my own clinical practice when thinking about neurodivergence as an umbrella anyway. Have you used that in your CAMS work, Matt, as well? Okay, that's okay. So we'll go on there.
I was waiting for you to say. Sorry.
So I guess if we're steering away from, we've kind of understood the trauma part, and Matt, we were talking before this as well, and you said something quite poignant in that it's quite easy to remember the co-occurring neurodivergence when we're thinking, we know a lot more around hypermobility, DCD, ASC, and the co-occurring ADHD now. But you were talking about physical health as well, which, and I think sexual health and physical health are two things that we often forget to review within our clinical practice. Any thoughts?
I made it quite a regular part of my clinical practice. Where I used to work was quite a deprived area. So a lot of families didn't have easy access to things like healthy foods. I remember clearly there was a child drinking a Monster Energy drink in the waiting room for the ADHD assessment, which actually led to a very different line of questioning than perhaps I would normally. So it was to thinking about diet. Some of the research I was looking at prior to today was thinking about obesity. And actually obesity and ADHD, as a child, I think the risk goes up 70%, and as an adult, it's 40%.
And is that the link with binge eating disorders? Because I'm aware that there's an increased prevalence in type 2 diabetes and ADHD as well.
I think so. And I think when we consider those co-occurring needs where the impulsivity is, I need to eat now, if we're thinking about food or eating disorders, and it's more difficult to turn that off if ADHD is also part of the picture. It's very easy to be very impulsive or even forgetful. If we think about some of the executive function, it might just be, I plan to do that. I'll do some meal prep. We've all been there. Get it all ready, and actually you forget about it, or it sits in the freezer because it's not on your mind.
Well, and in that similar bracket to kind of eating disorders and disordered eating, we also have ARFID, which seem to be a lot more prevalent post-COVID. So that's avoidant restrictive food intake disorder. And we know that if our body is starved, it impacts us cognitively, doesn't it? So you become more inattentive. Your executive function is impaired as a result of not getting enough food and drink and that sort of thing as well. I don't know if any of you have had experience with eating disorders or disordered eating within your ADHD assessment.
The most that I've seen is just following from Matt is like a lot of binge eating with the patients is like an emotional regulation thing as well. And again, like, yeah, it's what you were saying about that, seeking that reward, like not having that kind of just, you know, a lot of eating there, and it would become less apparent when they were being treated for ADHD, which was quite interesting as well. But what I've sort of seen a lot as well within the adult population is just going on from what, and I'm changing the topic here, when you touched on sex as well, like sort of unhealthy attitudes towards sex. Actually, no, I don't think that. It's not my place to say whether someone's got an unhealthy attitude towards sex, is it really? I don't think so. No, it's like, perhaps like, yes. So yeah, like, you know, not practicing safe sex, not enjoying sex as someone should be because of the sort of inattentiveness. And when you kind of ask them questions about that, because it's a huge part of people's lives, really, sexual health. And I think we often shy away from that subject. And when you're assessing, when I've been, you know, assessing someone's impairment related to ADHD, I ask them about sex and relationships. And then they almost like seem a little bit like, oh, why are you asking me about that? That's a bit weird. But then when you ask them about it, well, okay, like tell me a little bit more about it. Like, do you know, what your relationship's been like? What's your sexual health been like? And then they start telling you about it and they're like, actually, yeah, I've, you know, been, you know, I have multiple partners because I'm constantly bored with one person, which is fine, absolutely. And they're like, but yeah, I don't necessarily practice safe sex. I sometimes put myself in unhealthy situations because I'm looking for that dopamine. I'm often intoxicated. And then when you kind of explore that further, it definitely links with ADHD and behaviour patterns.
Yeah. There's elevated prevalence of teenage pregnancy in ADHD as well, and a large part of CAMHS and paediatric clinics is having that safe sex discussion with consent from the parents as well. When I was working in East London, our building was physically close to a sexual health centre, and so we did joined up working, which was fantastic in order to help kind of protect the well-being of the young person, but also manage things like sexually transmitted infections. Because although we're seeing someone for ADHD, they're coming into our clinic, we can't ignore that there are other elements or other conditions that they may have contracted which are associated with this impulsivity linked to ADHD as well. And kind of going back along the lines of physical health needs, quite often see things like lower iron levels. We know particularly in females, low ferritin levels can be linked to ADHD and exacerbate inattentiveness. You get restlessness behaviour. And so understanding diet, food intake, but also have they seen their GP? Have they had regular checkups? And Penny, I feel like this is more your domain.
Like,
yeah.
and I think your works of co-working, co-production with other agencies is just key to this. And I think what we're talking about is not particularly disjointed, but we just need to rejoin, because there's so many different agencies that we're all talking about that interlink to this sort of what this neurodiverse umbrella. But we can see very clearly that there are so many other
complexities.
Yeah, exactly.
Yeah.
And it's looking at, and I can imagine that people are thinking, my goodness, how are we going to build all this together into our assessment? So it's about thinking about, where do we start with this, and how can we use strategies to support, you know, sort of our clinic environments that we've all been in, to really get a good assessment, a quick assessment to support these patients. So do we need to start looking at sort of a digital type approach? And I know the task force is looking at that at the moment to get a more sort of really structured, detailed assessment for for people with ADHD symptomology.
And actually, that was going to be kind of leading into my next question, because we're all here. We all, by coincidence, happen to be nurses from slightly different backgrounds. We've got mental health, health visitor, and general practice. But what's fantastic is we're seeing a lot more GPs enter with specialist expertise in ADHD. And actually, we are in this much needed movement of seeing ADHD moving into primary care. And I appreciate there's pressures amongst the whole system, but we've had the privilege of working with some very talented GPs who view the ADHD profile different to those of us who have been trained within a mental health where we're quite focused on anxiety, depression, self-harm, suicidal ideation, but they may be looking more around the physical needs or that kind of first entry into the referral system. And when I worked in pediatrics, I had a much broader MDT, which was combined with speech and language therapists, occupational therapists. So we were able to unpick sensory processing needs and how that child moves and what can look like hyperactivity, speech and language disorders, expressive and receptive, that can look like inattention. So when we kind of take it a step back further, and we've got GPs who can do blood tests, they can check ferritin levels, thyroid levels, but just think about the general health of the individual. That feels like a real powerful stance to broaden our MDT, our multidisciplinary team, to meet the needs of our patients. But also, when we're thinking about complexity, we're not waiting for the referral to the specialist service. We're getting insight at each point along the way.
And signposting to the community
Yeah.
for support, rather than using our very expensive medical system or NHS system. So no, it's about supporting that individual patient's needs at that particular time, particularly if they are on a waiting list for an assessment.
And do they need to be on that waiting list?
Yeah.
If we identify early on what's going on, then we've got them on the right trajectory to get the right support at the right time.
And again, you've heard me go round and round with proportional care in ADHD, which we haven't quite got there yet, but I think we're coming round to it. And if you look at our physical health colleagues in orthopedics or cardiology, for example, if you tripped over in the street and sprained your ankle, your first port of call isn't the consultant orthopod, is it? You're not going straight into surgery. What you're utilising is the expertise of people in other services in order to get you to the right person at the right time. So you, as the patient, your time isn't spent on long wait lists, but you're getting the right care for the right condition at the time that you need it. And I think you're right, Penny, thinking about the task force data, and the shift we're hoping for is that needs-led approach, but also in terms of managing complexity. If we can empower people to access through digital tools or waitlist initiatives, earlier intervention, by the time they've been on their waitlist for ADHD, which we understand is long in the UK at the moment, the problem is not so chronic that the individual's symptoms become exacerbated and worse because they've not been treated at any point in that journey.
Yeah, no, that's really, it's definitely something we should work towards. It's like not just intervening when they come in for their appointment with a consultant psychiatrist. Like, we've got a whole line of professionals that can intervene, like nurses, psychology assistants, having like effective triage system, and actually realizing maybe it's not ADHD, maybe it's something else, and then signposting them to other services, like charity organizations, like family support, things like that. It's definitely something that we can, like starting at primary care is definitely something we should be doing, rather than just waiting for them to come to like secondary services.
And we've all worked in the NHS for a long-standing period of time, and we understand the pressure on resources and where this comes in. But it feels like in order to cut through the complexity and understand the comorbidity, so that when you get to the ADHD clinic, you can say, is this ADHD or not? Because other co-occurring needs have been considered, intervened with. I was having a discussion yesterday actually about someone who was coming for an ADHD assessment and had put in a huge amount of personal work to enter into therapy prior to doing that. And actually, the symptoms looked very different because they had understood their trauma, done a lot of work on themselves, and actually an ADHD diagnosis may not have been appropriate because they saw the right individual at the right time. And so whilst there was neurodivergence, and that was something important to consider, it was offering them the right solution at the right time, and therapy was that. So it sounds like we're saying managing complexity comes at different levels. Once the individual who's having an ADHD assessment has got to us as specialist clinicians, it's our role to ask broadly around physical health, mental health, dialing it all the way back into their early history, particularly if there are adults, understanding onsets of co-occurring conditions, interpersonal relationships, thinking about attachment styles in younger ones. But also considering us as clinicians, managing complexity through changing the system and broadening our MDT by not going, okay, we're the specialists, we're going to hold on to ADHD, but actually we're going to work with our primary care colleagues, our sexual health colleagues, our dietitian colleagues, and consider the person as a whole in order to empower them to have the right care plan for them and their symptoms.
Absolutely. And so I therefore think we're looking at empowerment and education together, very closely together, to manage these complexities.
Absolutely. Okay. I think that's the perfect place to kind of lead that discussion to an end, as it would be easy to kind of carry on talking. So thank you for your input today. Thank you to those listening today as well. That has been Rethinking ADHD, and we have been thinking about managing complex cases and getting clarity in complexity. See you next time.